And thanks for the department to inviting me to talk to all of you about one of my favorite topics, which is global health. Now, my assigned topic was international medicine, what do developing countries need? So I started making my list, and I started with workforce capacity, and in the School of Medicine, you probably don't all know there are 30 departments already, including lab medicine, pathology, and radiology that are all pretty critical in many areas of diagnosis and care of patients. But nursing is key in developing countries, pharmacists, public health specialists, dentists, social workers, community health workers. Then we need to think about equitable allocation of funding across the four key sectors of education, health, poverty, and infrastructure. Health leadership and management are key. Health leadership management training, integrated health systems development is essential. And I began going down the list here, and I realized I was running out of room, and I was never going to be able to cover the needs. These needs are so overwhelming, particularly in the areas of laboratory medicine. So what I decided I would do is try to really focus. And I'll focus today with this group on the nature of the problem, on the Millennium Development Goals, if there's time, on disease control priorities and some of the best buys for health in developing countries, a bit about, it's timely to talk about the threat of pandemics, now that we're dealing with whether WHO will call swine flu a great level 6 pandemic, and surveillance related to that, which is key for laboratories. The role of laboratory medicine, and also not only in medicine but in public health, and then strategies for implementation of laboratory science. So first, what is global health? And I always get asked that in the beginning. So let's just say we've gone through sort of eras of first tropical medicine, then it was called geographic medicine, then it was called international medicine, which was my assigned topic this morning. But the nomenclature has gone on to international health and global health, which is what we call it today. Global health implies global interdependence for health. And it's really not a discipline like, let's say, laboratory medicine is. It's a broader field rather than a discipline. It really seeks to enable every discipline, including laboratory medicine, to work more effectively globally and to understand and solve the problems that cause the greatest morbidity and mortality. So that's what global health is. Now, to get into what the nature of the problem is, this is a typical view. This is a primary care clinic, a health post, it would be called. Patients show up at 8 o'clock, and the community health worker comes up, and he is confronted by all these people waiting, and this is what he has to work with. In the pharmacy, basically nothing. In the laboratory, basically nothing. And he has maybe a few vitamins, and that's what he has to offer. And in the hospitals, these are typical hospital wards. Many hospitals I've seen it look like this. Here's actually when you run out of hospital space, you might use a church. And there's this enormous problem of mega cities and mega slums emerging. This is an area in Kenya where many people from the UW work. In Nairobi, this is the Kibera slum, the largest slum in Africa, where you have enormous crowding, poor water, poor sanitation. These kids, I have pictures of them playing in the sewers. The number one cause of fever in a study CDC is doing is typhoid. Poor nutrition. These are the problems that one is dealing with. In terms of workforce, this is the fraction of American-born physicians who actually reside and work in areas abroad out of their own country. So here you see at the top Mozambique, almost 80% of the physicians are working in other countries who they trained. And then you kind of go down the line. Kenya is about 50% are working in other countries. So similarly for nurses, it's a huge loss of workforce. Now the problems are diverse and changing, just as here. Interestingly for children, the leading causes of death are mostly preventable. And as you see here, kind of going down the list, most common, most important perinatal conditions, lower respiratory infections, diarrheal disease, malaria, measles, all of these obviously preventable. Congenital anomalies, not preventable. HIV/AIDS, preventable with PMTCT. pertussis, tetanus, and protein energy malnutrition. So these are the major problems in children. And the Disease Control Priorities Project, which has been led by Dean Jameson, who's now a member of our Department of Global Health economist, has identified the major global burden of disease in terms of disability-adjusted life years, or DALYs, in 1990 and the projections for 2020. And in 1990, it was lower respiratory infections, diarrheal disease, perinatal diseases, depression, ischemic heart disease and cerebrovascular disease, TB, measles, traffic accidents, congenital diseases, malaria, obstructive pulmonary disease, and so on. This is shifting as populations get older to ischemic heart disease, depression, and road traffic accidents as numbers 1, 2, and 3, followed by the others listed here, some of whom appear for the first time, like self-inflicted injury. Now, there's a real non-alignment of what the major problems are and what the United States government invests in. And I have mixed feelings in showing you these data, because I'm among those who benefit from this malalignment. But you can see here the top causes of death on the left in low and middle income countries for people under 70. And you can see that things like injury, non-communicable diseases add up to more than half, and maternal and child health quite a bit. So the infectious diseases are really about a third. On the other hand, you look at how the money we have from U.S. global health aid, and it's hugely HIV/AIDS and other infectious diseases, and a bit for maternal and child health and nutrition. So there is this misalignment. We talk about the 3 phases of global health, and the one we're in now, and evolving into the chronic disease phase, is the infectious disease phase and child and maternal health, which we call the unfinished agenda. So many of these things are preventable, but we're having trouble still dealing with it, particularly in Africa. The next phase, phase 2, is the chronic disease agenda, where with increasing aging occurring globally, we're dealing with the diseases of the elderly. Heart disease, stroke, cancer, mental illness, diabetes, and so on. And the future agenda that we predict is going to be increasingly related to the environment, environmental hazards, obesity, traffic accidents, climate change, addiction, and tobacco. And here's the shape of things to come. This was in The Economist. As I look around the room, I don't see many people that can really identify closely with this, other than me. But, and interestingly, the Disease Control Priority Project also, in its publication number 2, indicated what they felt were the 10 best buys for health. And the best buys they felt were general now, very general: preventing neonatal mortality, ensuring healthier mothers and children, promoting good nutrition, reducing cardiovascular disease deaths, stopping AIDS, stopping TB, controlling malaria, combating tobacco use, reducing injuries, and then ensuring equal access to health care. Now, there was an interesting exercise carried out last year called the Copenhagen Consensus in Copenhagen, and they looked at a little more specificity of where is the biggest bang for the buck in investing in these interventions. And for tuberculosis, they identified appropriate case finding and treatment of TB as the highest cost benefit to cost. And interestingly, dealing with low-cost acute management of heart attacks was ranked second. Prevention and use of artemisinin combination therapies was third. Vaccine coverage for childhood infections was big. There was an article by Chris Murray's group here in the Lancet December 14th that showed that the Gates and Gavi funded rollout and expansion of childhood vaccines was grossly overestimated by over and false reporting from developing countries. So coverage remains a big problem. For cancer, heart disease, and other, interestingly, the major intervention promoted is tobacco taxation, a policy intervention. For HIV/AIDS, combination prevention, which I've been pushing, and for levels of care at the district hospital level, increasing surgical capacity to deal with injury and difficult childbirth and other emergencies. So given all those, we still have to deal with the problem of emerging and pandemic and re-emerging infectious diseases. Here's a summary that includes examples of newly emerging, re-emerging, and deliberately emerging, in the case of anthrax, infectious diseases. You can see way over here on the right, if I can get this, is the avian flu. And now we have swine flu. So this is what you see now when you go to the restaurants, the threat of pandemics. And I don't know where this will be heading, but everybody's carrying Purell. How many of you have Purell in your pocket now? There are just a few. A couple of weeks ago, there were a lot more. Global health and global infectious diseases knows no borders. This is the daily routing where there's at least one flight across countries. And we really have incredibly globalized. So for global infectious diseases in humans, this summarizes the importance of animal-to-human transmission. There are 57 million deaths annually for humans from these infections, and of course many more in animals. 63% of all deaths in sub-Saharan Africa are from infectious diseases still. 6% of all deaths in high-income countries, so much fewer. The number of disability-adjusted life years lost annually globally is 1.3 billion. This is a good one. There are 1,415 different species of pathogenic organisms that cause disease in humans, and many more in animals. There were 335 newly emerging infectious diseases from 1945 to 2004. This included newly antimicrobial resistant strains. And of these new pathogens, 75% are zoonotic. How do these zoonotic diseases emerge? And I have a few slides to show here. This is I got this slide from Dan Rocky at Oregon State University, who studies chlamydial infections in in pigs. And he sent me this, and a couple of people asked me for it. I got his permission. There probably are 1 million people in the world now with swine flu who have this and are showing this slide at their presentations. But there are more. This suggests that petting zoos are maybe not the safest things to bring your kids to. I guess this is Bartonella from this kitten going to this little girl. Here's a really thirsty little guy. And the horse looks disgusted. And the slight alarm on the face of this kid as he's wondering where his bottle went. So there are many ways that animals give rise to these infections in humans. And we collaborate closely with the new Washington State University School for Global Animal Health and looking at the animal-to-human infectious disease interface. Now, this is the global map of emerging infectious disease events. And the interesting thing is that where these have been picked up is up here in Europe and in the U.S. And although there are some occurring here and here, very few. Now, do you think this is really because the emerging infections are not occurring in these areas? It's really because they're not being picked up in those areas because of the lack of surveillance mechanisms, the lack of public health and diagnostic labs for medicine. So what is the role of lab medicine and clinical care and public health in developing countries? Well, as you all well know, it ranges from screening to clinical diagnosis to staging disease to therapeutic monitoring to blood safety to genetics to environmental safety, surveillance and outbreak investigation, and biosecurity. Now, interestingly, we had a meeting in Kenya just last month in which 4 U.S. universities sent members, including people from the UW, and 4 partner universities in sub-Saharan Africa that included Botswana, Tanzania, Uganda, and Kenya. The meeting was in Nairobi. And the first panel, we asked representatives from the African universities to tell us what did they think were their biggest needs from their partners in the U.S. And the things they mentioned were leadership, management, and policy training, integrated health systems development, training in how to carry out operations and implementation research, integrated team training of physicians and nurses and other healthcare specialties together, and informatics. What struck me as surprising is that no one mentioned clinical laboratory medicine and diagnostics as a need. I found that paradoxical because it's such an obvious missing component in Africa. And the basic problem there, and part of the reason for their not listing this, is current laboratory testing is of such poor quality and with such limited access that the diagnostic approaches are clinical, with clinical diagnosis being syndromic, meaning based on the medical history and physical examination. So that evidence-based decision-making is not practiced because clinicians believe the quality of testing is poor. And as a result, no investment is made in laboratories. That just continues the cycle of the lack of evidence-based practice in developing countries. So how does medical practice in developing countries differ from the practice in developed countries? And I'd like to give you the perspectives I'm getting from other grand rounds I attend, from UW medical students and house staff and junior faculty who are returning from the international rotations that we help them go to. The surgical residents in particular come back noting the amazing lack of equipment and how they discover that they can do surgery they never thought they could do without any equipment. And they are amazed at the fastest cesarean section they've ever seen performed. The emphasis is on very efficient, high-throughput efforts with task shifting to non-surgeons, midwives, clinical officers, and so on. But the internists and pediatricians all note the biggest difference between what they do here and what they do there is almost the absence of access to any diagnostics. So the therapeutic decisions are based on the medical history and the physical exam, and the reliance on syndromic management and therapeutic trials. And I'll tell you the distinction between those in a second. In terms of public health practice, first of all, public health practitioners are very marginalized in most developing countries, not all. And lab systems for public health are largely non-existent. So the key approaches to clinical management, the traditional etiology-based treatment is largely based on rapid point-of-care testing. And this is gradually emerging. The best example is the rapid HIV testing, which is routinely used for the diagnosis of HIV, particularly in perinatal settings, but increasingly everywhere. Syndromic treatment, based on symptoms and signs of disease, involves, for example, for infectious disease, the use of combinations of antimicrobials that will cover all of the leading possible causes of the syndrome. And I'll give an example or two. The therapeutic trial differs in approach, and I think in some ways it's the most common, although it hasn't had much press for this. The idea here is to give a single, the cheapest usually, antimicrobial for an infectious disease syndrome, and then follow the patient, which is tough because so few come back. If there's no response, then try a different, maybe more expensive antimicrobial, depending on the syndrome. And if there's still no response and the patient's sicker, then consider doing at that point a diagnostic test and trying to guide etiology-based therapy. So an example here would be urethritis. And a specific diagnosis-based approach would be to do a microscopic exam of a gram stain or a methylene blue stain smear and see what I guess we're seeing here is gram-negative diplococci, make a diagnosis of gonorrhea, and treat with whatever the drug is for gonorrhea. Syndromic management would be to treat with a combination of antibiotics effective against chlamydia like doxycycline, plus cefixime if they can afford it, or ciprofloxacin, for all of the more common causes of the syndrome, gonorrhea and chlamydia, for example. The therapeutic trial would be to begin with Cipro for gonorrhea, and if there's no response, switch to doxycycline for chlamydia, and if there's still no response, switch to metronidazole for the possibility that it might be due to Trichomonas vaginalis. So that's sort of the three approaches. And I would say that syndromic approach for urethritis is now the leading approach. But for other diseases, let's look at genital ulcer disease, for example. Here, the specific diagnosis would be to do a rapid plasma reagent test and a TPPA for treponema pallidum, and to rule out syphilis and to treat syphilis if you find positives. That would be the specific diagnosis approach. The syndromic approach would be to give benzathine penicillin G first to cover syphilis, plus azithromycin to cover chancroid, plus acyclovir to cover herpes. So you're covering all three with broad-spectrum syndromic management. The therapeutic trial would be to give benzathine penicillin for syphilis, the worst possible cause, azithromycin if there's no response to cover chancroid and syphilis, and then acyclovir if there's no response to deal with herpes. Here's an example of where you can really get in trouble. It's so common, someone comes in with a productive cough. There's no chest film, but if you had it, you'd do it. And if it suggested tuberculosis, you do a Zeal-Nielsen stain of the sputum if there was suspicion for tuberculosis. Now that would be the ideal, but it's rarely done for people with cough because of lack of X-ray. So the syndromic approach would be to typically, if it's an HIV positive person, for example, you give amoxicillin to cover most bacterial pathogens, and sulfamethoxazole trimethoprim to cover Pseudomonas BCP. I'm sorry, pneumocystis carinii pneumonia. And the therapeutic trial, on the other hand, which is very common in this condition, in this setting, would be to give amoxicillin. If the patient doesn't get better, then you're thinking about PCP, so you give sulfamethoxazole trimethoprim. And if the patient still isn't better and comes back and isn't dead yet, you then you do the Zeal-Nielsen stain to rule out tuberculosis. Think of the number of people being exposed and the morbidity related to that. And here's another example that's more public health related. The World Health Organization's strategy to deal with this emerging mega problem of multi-drug resistant TB is to do what are called ICF and IPT, intensive case finding, and isoniazid preventive therapy. The problem is that intensive case finding requires better diagnostics for TB and X-ray to rule out pulmonary TB, and it's just not available in any rural area. And isoniazid preventive therapy requires the radiology to rule out active TB, since you're not going to give single drug INH preventive therapy unless you've ruled out active TB. And it requires long-term follow-up to monitor prophylaxis adherence, which is also a very difficult problem in these settings. So it's both the laboratory and the clinical problems with the control of TB. Now, if you write anything down from this talk, it would be these series of 6 papers that were published in Nature in November of 2006. This stemmed from a series of studies done by the Gates Foundation and led by Rand. And I was able to take part in a couple of them. It was an interesting process. They talked about global health diagnostics, reducing the global burden of acute lower respiratory infections, STDs, HIV, AIDS in infants, tuberculosis, and the burden of childhood malaria in Africa. Interestingly, there was a diarrhea group, and what they came up with was screen water to prevent infections. They didn't recommend anything for diagnosis of etiologies of diarrhea. Another paper that might interest you is this, we coined this title, Rapid Point of Care Test, the Way Forward is Assured. The basic problem is, this is the mean distance to the nearest medical facility in a series of countries in Africa, ranging from 4.7 kilometers to 26.9 kilometers is the mean distance to the nearest medical facility. So how are you going to get people to come in, get a test, go home, and come back the next day for the results, or 2 or 3 days if it's not point of care? And the roads are tough in most of these places. So Assured, the ideal rapid test is that it's affordable, sensitive, specific, user-friendly, i.e. simple to perform with minimal training, robust and rapid with tests available with results in 30 minutes, equipment-free, and deliverable to those who need them. Now, we are undertaking training in development of point-of-care diagnostics. And here's Karen Stevens is the co-host of this course. And it's funded by the NIH. This is the first year. And the goal is to bring and Pat Totten here is the co-director. The goal is to bring together bioengineers, microbiologists, clinicians, people from developing countries, chemists, present the problems in diagnostics, and help them to develop the understanding they need to proceed to development of science and technology around new diagnostics that are point of care. We think this is quite exciting. Now this slide is just to indicate to you that there are a lot of people trying to work effectively in this field. If you're the Minister of Health, these are the organizations likely to be represented at your doorstep on Monday. And on Tuesday, there's another group of 50 or 100. And they're just this uncoordinated, siloed approaches to tuberculosis, malaria, STDs, HIV, etc. And these sorts of uncoordinated efforts are not helping people in the developed countries to solve their problems. So what is the right approach? What I'd like to now do is thank Bob Martin, who's the director of the Division of Laboratory Systems in the Global Health Office at CDC, and works extensively, and I bump into him periodically in developing countries on development of laboratory systems. And he notes first the importance of the WHO forming the International Health Regulations in 2005. It was adopted by all member states and entered into force in June of 2007 with the expectations countries will be fully compliant by 2012. And part of these regulations are that the national public health system should establish the laboratory capacity to identify, monitor, and report to health authorities on agents that may cause epidemics and emergencies, including those of international importance, in a safe, timely, and reliable manner. Currently, this basically does not exist, with so few exceptions. Mexico, a good example, very well developed in public health, and yet for the diagnosis of swine flu, they sent their specimens to Canada, and the U.S. lacking the ability to do that in Mexico itself. And this is one of the most advanced of the middle-income countries. And the statement was that every national public health lab system should institute a national quality assurance program that includes standards, quality controls, audits, external quality assessment, biosafety, biosecurity, and maintenance. Now, I'd like to take you through a little bit of this briefly to give you a sense of what we are trying to accomplish in developing countries. First of all, as with clinical systems, there's a need for a national reference laboratory with senior health scientists, which are often totally lacking in some developing countries, with a few regional reference laboratories that have senior technologists. Technologists are the ones who run most of the labs in Africa, for example, which then serve referral hospitals. And these referral hospitals serve primary hospitals or district level hospitals, which in turn serve health centers. And this is as far down as the laboratory systems go, although each of these health centers typically would serve 5 health posts. These health posts are very rural, staffed by a community health worker, and would have no laboratory access. So that's the sort of system that's being sought as an integrated clinical service support. The approach to training and development of these systems is to, first of all, and I'm talking to you about this because I'm hoping that many of you will be interested in this area and be interested in making a contribution, and you'll see how it's being done. So first is to carry out a gap analysis. What's missing, what's needed, and the introduction of concepts with leaders in the field. Do strategic planning, training of trainers who will train most of the others, and then have tiered rolled out of training through workshops, leadership training, and so on. You're probably all familiar with the terms of pre-analytic, analytic, and post-analytic as topics for policy and standards. And so for the pre-analytic area, it's test selection, preparing the patient, test requisition, labeling the specimen, arranging transport, and safety. Here are the analytical issues: specimen processing, storage, reagent preparation, preventive maintenance, quality control, method validation, evaluation, test performance. I have to tell you, none of this is being managed at this point in these countries. And post-analytic, reviewing results, quality control review, reporting systems that go up to the central level, results interpretation, and records. And the 12 quality system essentials that have been identified by WHO that I'm also sure you're familiar with, or should be, is organization, personnel, and equipment, purchasing and inventory, process control, information management, documents and records, managing unusual occurrences, assessment, process improvement, customer service, and facilities and safety. These are each separate systems that need to be addressed. And the beginning is national laboratory policy, which I doubt is present in any of the countries we work in now, with the development of national strategic laboratory plans as the foundation for developing sustainable laboratory health systems. It's important to be familiar with the ISO 9000 standards for application of quality management systems for laboratory services. There are many ISO standards for things unrelated to health or laboratories, but these are the important ones. How many of you are familiar with these? So I see very few hands. That's surprising. Here are the implementation strategies. There are 8 key interventions identified by WHO and CDC, and here are 4 of them. Strengthening lab management at all levels of the healthcare system, strengthening infrastructure and support, for example, procurement and avoiding stockouts of reagents. Another example of this is the first time I went into a laboratory in Mombasa, I looked through the laboratory book, and I found that they had been running in their syphilis file about 4 positives per page of about 30 tests. And that went on and on for a year. And then there was a whole page that was no positives, and then another page, no positives, and another page, no positives. And so I said, what are you using? And they said, well, we use these tests here. We got them from Belgium about the time that they all became negative. And the batch of free VDRL reagents they were using had expired like 3 years before they got them. So, I mean, the ability to actually look at the infrastructure and document this is critical. I would say there's not a laboratory that I have worked in or with in a developing country that hasn't had initial problems like this. Addressing human capacity development through training, establishing a national lab referral system, which needs an integrated lab system. And then the 4 remaining ones, a national QA program, developing a comprehensive monitoring and information system like the Laboratory Information System, LIMS, coordinating government and partner-supported lab activities. So not all the labs are government labs. Many of them are NGO-based, for example, or academic-based, and mobilizing resources to finance the strategic plan. There are some examples of approaches that are not exactly point of care, but are higher technologies trying with the goal of being adapted to a developing country setting. And these are sort of at the cusp, I would say. One is the use of LED ultra-bright microscopes, which are, some of them, although I've seen them up to $2,500. Some of them are much cheaper. They have a long lifespan, low power consumption. They can be battery operated, don't need air conditioning or dark rooms. Because they're quicker, the technician workload is lower, and the diagnostic performance is higher with, for example, compared to standard fluorescence microscopy or Zeal-Nielsen stains have a much higher yield. And Cepheid, with its expert MTB system, is also being promoted as something that could be applicable at the regional or central level to detect multi-drug resistant TB, for example, by identifying rifampin resistance. And then just before kind of closing, to take you through some examples of systems where we've been working. This is the entry to the Tambaram Thoracic Hospital in Chennai, India, where both Bob Martin and our ITEC program have been working. The hospital specializes in respiratory disease, tuberculosis, and with the CDC we helped establish their HIV program in this hospital. So you'll be interested in these pictures. This was the laboratory when we first began, and I guess that was 2003. This is the laboratory today with CDC funding. This was the one of the laboratory rooms where you came in, where they weighed things out. That's that same area today. This was where they did their staining. It was very colorful. I've been to one lab where there was a little fluid would just run off, and there was like a river that was stained kind of blue, Zeal-Nielsen blue, as it ran away from the building. And here's the facility today, same room. You'll love this one. This was their BSL-3 hood, and you can see where it opened. And here it is today. They actually have a biosafety hood. And here's the microscopy laboratory. And they have some equipment and informatics, and this is the same hospital, government hospital of thoracic medicine. So this is the effort now is to make this part of a system within India where the opportunities are better than average for example, in comparison with sub-Saharan African countries. We had a class recently that was a class for about 120 undergraduates and medical graduate students, medicine, nursing, and so on. And at the end of the talk, I asked them as a group with an audience response system to advise me what should be the top priorities for the Department of Global Health to improve global health, and to choose one. So the options were to strengthen our existing infectious disease and Institute for Health Metrics and Evaluation, to develop 2 to 4 new interdisciplinary global health centers other than infectious disease related, to fund international health rotations for UW students, including those in lab medicine, house staff, and so on, develop an undergraduate global health minor, strengthen health sciences education in developing countries, and advocacy, diplomacy, and policy for global health justice and equity. So I'll show you what we turned the clock on, and 10 seconds later, this was their vote. And it was very interesting that although they were the ones who would benefit for international travel, only 7% thought we should be focusing on that. 18% thought we should develop an undergraduate global health minor, which we're working on. The highest number thought we should be focusing on strengthening health sciences education in developing countries. And I think the theme of what I'm talking about here is that should be our focus, at least a big one. And then clearly advocacy for global health justice and equity and funding for these programs. I would also tell you that in terms of the learning objectives for the course, for this lecture I should say, I suggested, did you get learning objectives handed out to you? Okay, I suggested that they should be to identify what UW Laboratory Medicine as a department and you personally as individuals could and would like to contribute to reduce global health disparities. And first through science and technology, for example, working with bioengineers on point-of-care test development or evaluation. Second, through training, mentoring, and quality improvement, either working in those areas here in Seattle with trainees from other countries or abroad, or through establishing partnerships with clinical or public health institutions in developing countries for longer-term faculty-related activities. And I hope that some of you will be interested in that. I would say that most of the departments that we interact with here, basic science or clinical, are now very actively promoting global health rotations for their students and residents and fellows. And we would like to be able to help with that. We have a website that you can look at. And this website includes a map, and you can click on that map. Actually, Bobby Nodell is sitting here who developed it. And you can see the 70-plus countries where our faculty are working, and many times with institutional agreements. And you can click on the country and see, the 170-odd projects that our faculty are carrying out where they're located. And those are people that you could contact to explore interests that you may have. Someone came up from India and said they were interested, for example, in India. And those are areas to potentially begin interactions with global health. And with that, I would like to say thank you very much and take questions. Thank you. I should also say that I know that many people in lab medicine are incredibly active internationally, and I work with a lot of them, and this is already an internationalized department. Yes?
How does one reconcile the obvious goal, I think that the people in your survey answered that we need to strengthen health education, with the earlier slide that showed that such a large percentage of people who get, it seems, educated as physicians in those countries leave once they get educated?
Yeah, that's a great question. How do we train people in other countries and at the same time avoid training them and helping them leave the country? I'd say we have, through our Fogarty Center, trained close to 200 people in Kenya, Peru, Mozambique, other parts of Africa, India. And with the exception of one person from China, a couple from the former Soviet Union, one from Kenya, they've all gone home. And the way we've done it is to pick people after we've worked with them for 2 or 3 years in their countries before they come to work with us here, and then provide things for them to go back to so that they are not jobless. We pick them because they're integrated within a program. That takes a certain level of support, but given all the University of Washington has going on in these developing countries, it's quite possible. And we have kind of a sandwich program for those getting master's degrees or lab training. For some have had that, where they come here for the didactics, go home to carry out their research projects, maybe come back to present, and we continue to work with them when they go back home. That's one thing. The second thing is to do the training in situ. And so, for example, this meeting I mentioned we just had in Kenya, the Africans said we would rather have you train our people here, the people who've already gotten their terminal degrees. They have jobs at the Ministry of Health or the university. We'd like you to give them sort of an extended degree program where they come back to work with us on weekends. You give them things to read at home. They come for 2 weeks at the summer. But you keep them essentially like we do with people who have jobs, in hospital management or laboratory management here in the United States. So you don't take them away from their positions, and they still have the positions when they're done. Those are a couple of examples. I think that there are still a few countries where it remains so bad that the temptation to stay is high, but it's workable.
Kim, you have enormous experience in international trials, and I know that our experience in the Partners in Prevention trial and others has been to go into countries internationally and set up laboratories that are then very much in question as to their ability to continue after those trials end. Could you comment a little bit on how we can leverage that kind of infrastructure into a more sustained infrastructure in country?
That's also a really great question, Rhoda. I think what we do see is just what you say. I mean, where we do help set up laboratories in other countries, they tend to be related to our trials, whether they're HIV trials or herpes trials or whatever. So the laboratories are set up with respect to typically one or two tests, but not with the idea of developing a comprehensive lab. And when you leave them, they're kind of stuck with no ongoing continued funding. I think you're asking a very hard question to answer. I think if it's done within the context of a broader program, let's say it's a diagnostic laboratory at the regional or central level, where maybe you're training one or two people and you're not only teaching them how to do the ELISA tests and Western blot or the pocket or whatever, but you're also teaching them quality control and quality improvement and CQI, and that kind of spreads throughout the whole program. They begin to see it when they don't follow those guidelines that the level of screw-up is unbelievable. You gradually change. I think long-term involvement is critical. But I think also partnering with others with a health system like the CDC is trying to do or WHO is trying to do will be important. But it's not an easy question to answer.
So I really enjoyed your talk, and you commented that the sort of multitude of uncoordinated NGO and other efforts are not doing are good faith efforts, but have not done a lot to really affect change. So is there any solution you see to coordinating those or whatnot to really make them more effective?
You guys keep asking great questions. When I first started working internationally was with a program called AIDS Cap that was, I guess, about close to 20 years ago. And representing USAID, I would meet with colleagues who I knew from the European Commission, NORAD, the Norwegian group, and Canadian group, and so on. And we would have goodwill, good faith efforts to collaborate. But then everyone wanted their own imprimatur on the project, and so it proved difficult to actually integrate. There's been a publication from the UW that was, I think, the first author was James Pfeiffer, on ethical behavior of non-governmental organizations in terms of how they could collaborate, how they could integrate, how they could avoid jacking up their salaries to steal people from other NGOs or the government. You see these little cities starting that are called white cities because they're all of our NGO employees living in an enclave with a gate where the Africans or Asians live separately. So working to avoid that, I took part in a telephone call on Monday with the 4 university partners working in Ethiopia. And the purpose of our call once a month is to discuss how we can integrate what we're doing to avoid competing. And things like that, I think, are important. I think if ultimately somebody who's got a lot of money, like Obama, I hope will create incentives for agencies that are able to collaborate so that the level of funding will be higher if there is evidence of collaboration. So rather than being penalized for not being first, you're rewarded.
One of the areas that our department has developed is computerized training for competency assessment and generalized training. And I'm wondering how accessible and acceptable those would be on a worldwide basis as a way to either kind of extend community of people who have been trained or even to provide initial training.
I think that is actually a fabulous area that UW's lab medicine department could play a role. I don't know how difficult it would be to modify or adapt, for example, the program that you run that reaches 60% of the lab techs in the country to do something similar, seeing it grow over time. I think the funding would be there. I think, it's one of the things that we could really put a stamp on it as something that the UW offers that is quite unique. Similarly, in terms of distance learning in general, we're doing a lot on that. We have a team working in that area, and we haven't yet partnered with lab medicine, but it would be interesting to do so. It would take some funding, obviously, for somebody to run it. There wouldn't be the same requirement for being retested that there is in the States that helps funding it, but there could still be mechanisms of gaining funding from groups like the World Bank and UNAIDS and PEPFAR and so on that I think could help that. So should talk more about that. It's a great idea.
Well, very good. Thank you.
Thank you.